Hello everyone and welcome to this slightly longer video than usual. So grab your popcorn, your chocolate, tea, or whatever you like to enjoy while learning pathology, and let's talk a bit about this kidney tumor, which has been along with us for quite a while, so it's not a new entity, but has undergone a name change in the latest 5th edition of the WHO. And it went from being called clear cell papillary renal cell carcinoma to clear cell papillary renal cell tumor, and or CCPRCT for short. And indeed, these tumors are in more than 90%, even 95% of cases. They are small in size. They are less than 7 centimeters in size. They are confined to the kidney and show no local regional aggressive behavior, meaning they don't invade into perirenal fat, they don't invade the renal sinus, they show no necrosis, they are well circumscribed and encapsulated, they show no invasion into veins, into lymphatics, or into the renal calyces or renal pelvis. So they are in more than 95% of cases low-stage tumors, PT1 tumors, and they are almost per definition also low-grade tumors. They have low nuclear grade, nuclei of G1 or G2 on the ISUP/WHO classification of nuclear features. Now they may be multifocal, meaning you may have multiple tumors within the same kidney, or they may also be bilateral. But they are, like I said, they're confined to the kidney, they're well circumscribed, even encapsulated grossly and microscopically. So low stage, low grade tumors, and additionally, the data that we have gathered so far about these tumors has shown that they are indolent. They have an indolent biologic behavior. So this is the main reason for the name change, for the terminology change from going from carcinoma to tumor. Now this is the information that you'll find in the current WHO, right? But if you'd like a more nuanced discussion on the biological behavior of these tumors, there's a very recent case report that has been published, I think this year, in Histopathology by Sunak Gupta and colleagues. I'll put a link to it in the description below, so do check it out, where they describe a case of a metastatic clear cell papillary renal cell tumor. And they argue in this case report that actually we might have rushed in changing the name of these tumors in the recent WHO, and that we should actually revert to the previous terminology of RCC, of carcinoma. In this report, they fully characterized clinico-pathologically and molecularly the primary tumor and the metastatic tumor, and they proved to fulfill the criteria of clear cell papillary renal cell tumor as they are understood currently. So this begs the question, actually, is it justifiable to call them tumors and not carcinomas if they do show metastatic potential? And I don't want to go into further detail on this because otherwise it's going to be an hour of a video, but just to put things into context, the longest follow-up period we have in the current literature on CCPRCTs is of less than 2 years. So this actually brings up the point. Could it be that CCPRCTs actually behave like low-grade, low-stage CCRCCs, and that they do indeed have, in some rare instances, metastatic potential, just as that it doesn't manifest in the first years after the diagnosis of the primary tumor? So it could be. But do read the case report because it's interesting. Now let's dive a bit into the histopathological features of this tumor. So first of all, we're in the kidney, right? And Dr. Jason Hornig has this beautiful way of saying you always have to place your viewers into context. Like, don't take my word for it. We are really in the kidney. So this is normal renal parenchyma, right? And then we have a mass. It is well circumscribed. We can see sort of a pseudocapsule here at the periphery of the tumor. And the mass itself at low power, because I always like to start at low power to look at kidney tumors. In general, actually, it's always good to start at low power. So this tumor is at low power is partly cystic, not that prominent the cystic component, and mostly solid. And I like this particular example, which, by the way, disclaimer, doesn't belong to me. This is a slide on Path Presenter, which does not, again, belong to me. And if you haven't checked out Path Presenter yet, they have an awesome library of digital slides to review if you want to solidify your theoretical knowledge that you gather from books. It's like a good replacement of a surrogate of a microscope at home. So do check it out if you haven't already. Okay, going back to our tumor, I like this particular example because it has in the same tumor two, let's say, morphologies that you may see in this tumor. So let's first focus on this area. So it's solid, as we said. It has a prominent tubular growth. And actually, the first thing that we notice, so as to place our tumor in one of the morphological patterns of kidney tumors, is that it is composed of clear cells, right? These are the cells that you usually see in a CCRCT. The cytoplasm is optically clear. There's a nuance here with clear cells whenever we talk about clear cells, because if we talk about clear cell tumors as a pattern in the kidney, we have a range of differential diagnoses. And even papillary RCC, like pure papillary RCC, can have clear cell change. And when I talk about nuances, I mean the fact that, for example, in papillary renal cell carcinoma, as opposed to CCRCC, even with clear cell change, the cytoplasm tends to be a bit frothy. In papillary RCC, in this particular example, it kind of resembles the foamy macrophages that you have in the papillary cores. But in this case, it's truly optically clear as you would expect in a CCRCC. Great, so we have clear cytoplasm, we have a tubular growth, and we have cells that have a low nuclear grade. Like at low power, I do not see prominent nucleoli. Of course, if you go a bit to high power, you may see some here and there scattered, but mostly, like, you may have some cells that look a bit higher grade, but mostly at low power, this is of low nuclear grade. Now, another thing that I would like you to notice in this tumor is the nuclear alignment, how the nuclei sit within the cell cytoplasm. And if you pay attention, you might notice that at least in some areas, the nuclei tend to be polarized toward the apical surface of the cell, like here. They are like beads in a string of pearls or whatever. As you might have noticed, English is not my native language, so maybe I didn't got that right. But anyways, the idea is they seem to be polarized, organized in an orderly arrangement towards the apical portion of the cell. So they are luminally oriented. Okay, now let's move on and look at the other component of the tumor. Not to say that this is a tumor that usually has two phenotypes or two morphologies, or that is a biphasic tumor. Sometimes you only see areas that are like, you only see these short tubules with clear cells, with low-grade nuclei, and nuclei that are polarized toward the apical part of the cell. And sometimes you only see this sort of arrangement, as you would have it here. There is a striking difference in the sense that here the cells are more cuboidal. They have less cytoplasm. The cells here had a lot more cytoplasm, and that's why they also look cuboidal to low columnar, but they have definitely more cytoplasm than the cells here. So here there's a loss of cytoplasm. We still have that tubular growth. And this is characteristic of this tumor. I mean, characteristic. This is a very, it's not specific, but it's something that would sway you in the direction of this diagnosis. You have short, angulated tubules that are open, like have open lumina, and these have been very, very neatly compared to shark smiles. If you can imagine the mouth of the shark with the teeth. So short, angulated, shark smile-like tubules that are lined by these cuboidal to low columnar cells, which have low nuclear grade and clear cytoplasm. And in these areas, it's a bit difficult to see the nuclear arrangement because of the small amounts of cytoplasm, but if you look closely in areas that have a bit more cytoplasm, you can see that the nuclei are luminally arranged. Anyways, in areas where there is not that much cytoplasm, you can still see this orderly arrangement of the nuclei. They are not haphazardly arranged within the cytoplasm, but literally they just sit one next to the other in an orderly arrangement, be it luminal or basal in areas where there's not that much cytoplasm. Another thing that these tumors have is a stromal component, which in these tumors is sometimes of a fibromyomatous nature, like it's fibrous tissue with some smooth muscle in it. And actually, this tumor has a bit of it here, this fibromyomatous stroma, which would be unusual for a classic CCRCC. Another thing that this tumor classically has, and it's in its name. So we have seen the clear cell part of its name. Now here's a papillary part of its name, right? So it's a bit cystic. And it has these small abortive papillae that project into the cystic spaces. And the nuclei, again, are very orderly arranged. If in these areas we don't have that much cytoplasm, so again, it's a bit difficult to appreciate that luminal orientation of the nuclei. But then again, like we said, these are low-grade nuclei that are orderly arranged, be it apical or basal in areas that don't have that much cytoplasm. So we have tubular growth, short tubules that are angulated and sharp smile-like, and we have short abortive papillary structures, we have clear cells, and we have the luminally arranged nuclei. And these are like the major features of these tumors. And again, this fibromyomatous stroma, which we sometimes see in these tumors. There's a caveat regarding the fibromyomatous stroma. When it is prominent, it should make you make you think of another category of tumors, which are collectively called renal cell carcinomas with fibromyomatous stroma. I know, very ingenious name, but at least it's suggestive of what they show histopathologically. This is a distinct category of tumors that is a bit heterogeneous. In the WHO, you'll find them under the chapter of ELOC mutated tumors, because these tumors in the sporadic setting show recurrent mutations of the ELOC gene, which was previously known as TCEB1, if I'm correct, if I remember it correctly. I think that is its former name. But they can also be seen in syndromic settings, and when they do occur syndromic, they are seen in the tuberous sclerosis complex, meaning they are associated with TSC1, TSC2, and mTOR pathway mutations. But these tumors also have a bit of a distinctive morphology, in the sense that while in CCPRCT, we usually see short angulated tubules, in RCCs with fibromyomatous stroma, these have a sort of multinodular growth at low power, because you have like lobules or nodules of tumor that are separated from one another by thick transecting septa of this fibromyomatous stroma. So it's way more prominent, the stromal component. And the tumor itself, it has a tubular growth pattern, but the tubules are long and serpiginous, and they have lots of infoldings, and they collapse into themselves. The cells have plump an ample amount of clear cytoplasm, and there isn't this orderly arrangement, there isn't this polarization, apical polarization of the nuclei. So it's quite a distinctive morphology as opposed to what we're seeing here. They also can show papillary growth, but usually there are well-formed papillae as opposed to the abortive small papillae that we see in CCPRCT. Now, the main differential diagnosis of CCPRCT is, of course, CCRCC, and especially the low-grade and low-stage CCRCC. And you have to remember, while the nuclear apical polarization is an essential feature in the WHO for the diagnosis of this tumor, together with other morphological features and immunohistochemical and even molecular, which we'll discuss in a bit, this is not entirely specific for CCPRCT. There are occasional low-grade, low-stage CCRCCs that may show overlapping features with CCPRCT. They may show angulated tubules, and they may show nuclear polarization. But these CCPRCT-like tumors will typically have an so-called imperfect immunohistochemical profile. But before understanding what is imperfect for these tumors, we have to understand how they stain, the classic ones, the CCPRCTs. And for that, I'd like to show you a PowerPoint. Right. So CCPRCTs show a diffuse membranous expression of CA9, just like CCRCCs. The difference is not quantitatively, but it's qualitatively, in the sense that CCRCCs show diffuse, membranous, and circumferential expression of CA9, the so-called box-shaped pattern, meaning the cell membrane is stained on all sides. In CCPRCT, typically you have a so-called cup-shaped or basolateral staining pattern of CA9, meaning that the most apical portion of the cell remains unstained, and it resembles a cup. It's stained on the basal aspect of the cell, and the apical portion of the cell remains unstained. If you notice here exactly what I mean, right? CCPRCTs are diffusely positive for CK7, and this is in contrast to classic CCRCCs, which are tend to be more on the negative side for CK7. There is a thing with CK7. CK7, this is how I like to remember it. In the realm of clear cell renal tumors, CK7 tends to be more expressed in areas that are cystic. Like the more cystic the tumor gets, the more CK7 you're gonna see. This is true for CCRCCs that are cystic, and it's also true of multilocular cystic renal neoplasm of low malignant potential, this alphabet soup of a name for the tumor, that also is, per definition, entirely cystic and stains strongly for CK7, as opposed to a classic CCRCC. And I say in the clear cell realm of tumors because in the oncocytic realm of tumors, I tend to like to remember it this way. The more eosinophilic a tumor gets, for example, with chromophobe RCC and oncocytoma, right? With the chromophobe, we have the clear cell variant, the classical variant, and then we have the eosinophilic variant. So the more eosinophilic a tumor gets, the less CK7 it expresses, because we classically know chromophobe RCC will express more CK7 than oncocytoma in clusters of cells, but the more eosinophilic it gets, the more it tends to lose the CK7 expression and resemble an oncocytoma in that sense. But these are just like mnemonics and like games that I like to play with my mind just to remember these immunohistochemical patterns. I don't know if they're going to be useful for you in any way. But then anyway, CK7 diffusely positive in CCPRCTs as opposed to CCRCCs. This is CD10, which is usually negative. It may be patchy, but it's usually negative in CCPRCTs, and this is a higher power view of that CD10, which is in contrast to most CCRCCs, which are positive for CD10. This is another clue that you may use. And because it may be papillary, and it is, like sometimes it just shows the prominent papillary growth, this is amaker, which is negative, to differentiate it from papillary RCC, right? So apart from using IHC with cup-like CA9, diffuse CK7, negative CD10, no amaker, to differentiate it from CCRCC. Of course, in CCRCCs that also have high-grade areas, that also have necrosis and invasion, it's easier to differentiate. But sometimes, imagine in small biopsy samples, because they may have overlapping features, it's not always easy or possible to make a straightforward diagnosis of CCPRCT on a biopsy. Another differential diagnosis is multilocular cystic renal neoplasm of low malignant potential, because these tumors have cystic areas, as we have seen in this example here. They don't predominate, but in some tumors, the cystic areas may predominate. So one way to differentiate between them is, remember, CK7 will be diffusely positive in both. The CA9 pattern will show in CCPRCT this cup-shaped pattern, but the nuclear arrangement is very useful, because in CCPRCT you will see this new beautiful nuclear polarization toward the apical surface. Apart from that, these tumors frequently show GATA3 and high molecular weight cytokeratin expression in keeping with a distal nephron differentiation. Expression of GATA3 and high molecular weight cytokeratin is indicative of this distal nephron, distal tubule differentiation, and you may see it and also in other tumors. And they are also often positive for Vimentin, which you wouldn't see in a low-grade area, or not that often in a low-grade area of a CCRCC. Vimentin is more commonly positive in high-grade areas of CCRCC. Another differential is, of course, RCC with fibromyomatous stroma. So whenever you have prominent fibromyomatous stroma, especially if you have, like we said, long serpiginous tubules, think of that. And also, translocation-associated RCCs, especially those that have no as a fusion partner, tend to show this this polarization, this apical polarization of the nuclei. So like I said, this is not a specific feature. You might see it in some RCCs. You might see it in TFE3 rearranged RCCs, especially those with no. You might also see it in patients with von Hippel-Lindau syndrome. Patients with von Hippel-Lindau syndrome tend to have, or sometimes have, tumors that are morphologically very similar to CCPRCTs, but on the molecular level, and here is my bridging towards molecular, they are genomically related to CCRCCs, and they are classified as CCRCCs. So it's good to have a history of your patient to know if you're dealing with a syndromic setting. So CCRCCs, we know about them. They have VHL gene abnormalities. Usually they have loss of chromosome 3p. That's where the VHL gene locus is located. Now CCPRCTs have no recurrent genetic abnormalities in that sense. And most importantly, they have no VHL gene alterations. And this can be proven by fish, for example. What they do have is a unique metabolic profile. They show depletion of mitochondrial DNA with increased oxidative stress and accumulation of sorbitol. So they're more damaged on the metabolic level. But it's important to remember no VHL gene or chromosome 3p alterations in CCPRCT. For translocation-associated RCCs that may mimic CCPRCTs, think of young age of the patient. Think of psammomatous calcifications. Psammomatous calcifications are unusual in CCPRCT. I mean, if you see them, there's a young patient, and you would have reasons to consider a TFE3 rearranged RCC. You can do the immunohistochemical stain if you have a TFE3, or you can order fish molecular studies on the tumor to confirm, right? So yeah, I think this is everything I have on CCPRCT. We talked a lot. I hope you didn't get bored. I certainly did not, because like it helps me to learn. I'm also learning like you, so we're in the same boat. And I've also made a video, a shorter, much shorter, 5-minute, high yield, boards appropriate video on CCPRCT. So kudos to you if you stuck to the end. If not, go check that out. The link is in the description, and if you'd like to see more pathology content, check out my Kiko profile and my Twitter or X profile, and I'll see you next time.